Okay. So this one's a slightly longer case review than our usual ones, but it's mainly the antenatal aspect of it that I'm very intrigued to gain people's opinions from. I'm just waiting on Mr. Naguib, hopefully. Oh, I don't know why it's on a timer. Hopefully Mr. Naguib will be able to join us and give us some wisdom for this. Or if we've got any other obstetricians that are present, that would be fantastic, because I'm genuinely intrigued here. Oh, he's in. Fantastic. Okay, so this is your case tonight. This lady is a gravida 1 para-naught. She has a medical history of arthritis in her foot, age 17, which supposedly went away, and a BMI of 20. At 28 plus 6, she had an infection which was treated in A&E. At this time, she had a suspicious CTG, but she self-discharged in the evening. The suspicious CTG was due to 1 or 2 baroreceptor decelerations with no obvious reason. At 29 weeks, she had an ultrasound scan, which was completely normal. I think growth was around the 40th centile or something along those lines. And then at 41 plus 1, she had a measurement which showed a static growth on her gap chart just from the midwife's abdominal sort of symphysis fundal height. Following a doctor's review, the induction was recommended. However, she declined. So an urgent ultrasound was booked for the following day. Ultrasound showed normal growth. Baby was estimated to be 3701 grams on the 62nd centile, but we did note oligohydramnios of 1.7 centimeters, deepest pool, normal Dopplers. And at this point, she consented to an induction of labour. So she came in. I think I've got my days the wrong way around. So that was 41 plus 0 and then 41 plus 1. She consented to an induction. So at 41 plus 1, she was admitted. However, due to the fact that she was oligohydramnios, we normally recommend that these inductions are done on our labour ward. And there was a delay of 48 hours due to just crazy acuity on our unit at this point in time. So yeah, she wasn't seen to for quite a while, which was really unfortunate. All CTGs taken on Hope Ward prior to her induction were normal. We did them 6 hourly just in the lead up to her induction being started. Not quite sure sort of why, but I guess just purely for the reason of let's make sure that this baby is well, considering the oligo was detected so late on in pregnancy. And she had no history of SHROM either. I should have mentioned that. So it's the 24th of the month. She is now 41 plus 3. At 19:05 p.m., she is fingertip dilated and a ProPes was inserted. She had a previous CTG about half an hour beforehand, but I haven't included that one because, like I said, this is quite a long presentation, but we'll sort of whiz through it. As you can see, our baseline is sat at around 125 here. We've got some fantastic accelerations and her uterus is definitely doing something, although she's definitely not feeling any of this at the moment. She's getting some sort of tightenings, but nothing worth mentioning. No pain relief was required at this point or anything like that. And obs, as you can see at the top there, are all completely normal. So yeah, we continued. This is the rest of the trace. So again, accelerations, baseline remains sort of stable and our variability remains well as well, sort of tightening around 2 to 3 and 10 at this point. Cool. So we left the CTG on for a bit longer and then this happened. So she had plus fetal movements. It was noted that the previous baseline was a 125, 130, and this CTG was reported to be saltatory, and this was escalated to the obstetric registrar. Any thoughts on this one?
For me, with the previous normal CTG, I would be more inclined that to watch it a little bit more.
Mm-hmm.
There is no bleeding or anything, no.
Yeah? No. So yeah, intake membranes, no bleeding, and lots of fetal movements are felt here as well.
Yeah, yeah.
But yeah, just a very drastic change from the previous sort of 40 minutes. Baseline sort of looks as if you were looking at this initially and you hadn't seen the previous CTG, my immediate thought would be, okay, this baseline looks like it's sat at around 170, or even maybe a little bit less than that. But obviously she's reporting lots of fetal movements at this point. So that's sort of taking everything about the clinical picture into account here. And because of the fact that around 2054, what it looked like from the CTG, what appeared to be a deceleration from the previous baseline, obviously we moved her into a right lateral position, which I think anybody would have done in this situation. But actually, it's probably more likely, based off of what we've seen previously, that this baby was just returning back down to that baseline. So yeah, everybody was sat very much watching this and looking at it thinking, okay, where are we going from here? But yeah, baby is obviously very active. We know that when babies are super active, that their baseline heart rate is slightly higher, as ours would be, for example, if we were to go for a brisk walk or something along those lines. So yeah, the plan was just to keep an eye on it at this point, which is exactly what we did. This is it continued here. So her blood pressure remains stable and her pulse is 75, respiration rate 17, and a temperature of 36.5. So the lovely night team started and the doctors did a ward round at 21:35. And at 21:38, they removed the propess and examined her to find she was os closed. And they've actually noted that this CTG was saltatory at this point. Obviously, in ward round, we do look back to the previous traces, but I think purely based off of the fact that this baseline was very much raised for over an hour now, that's the reason that the decision was made to remove the propess. Anybody would have changed their decision, or maybe a different take on that?
Maybe I would have done a bedside ultrasound scan and seen what is the baby doing.
Yeah. I think that would have given us a really good indication, because if this baby's, well, having a bit of a dance party essentially in utero, then that could definitely make up for the reason why our baseline's gone from sort of 125, 130 all the way up to what looks like 160 here. But it's one of those CTGs, I see them all the time, where sometimes we're looking at it and we think, okay, is our baseline higher and are these decelerations, or is our baseline lower and these are accelerations? And it's not particularly common that, you see that, but this was definitely one where sort of cautionary measures were put in place as opposed to sort of sitting on it and waiting. But yeah, this was at 21:40 in the evening. This later resolved back to a completely normal CTG, as you can see here. So this is the next sort of 40 minutes. So the CTG was discontinued at the end of this trace, and the registrar was happy that it had returned to normal. And the plan was made to rest this CTG on this baby overnight and restart the induction of labour the following morning. Now, something that concerned me with this was the fact that at 22:30, this CTG was discontinued and it wasn't restarted until 8 o'clock the following morning. Whilst I appreciate that we're no longer on an induction of labour pathway whereby we need to have a CTG performed every 4 to 6 hours, the fact that this was then left for over 10, well, just under 10 hours before restarting, I would have much preferred to have been reassured by this baby CTG at some point during the middle of the night. I know that acuity was high on labour ward at this point in time, so that's got to be taken into consideration. But having what you've thought is an abnormal antenatal CTG that's normalized, how do we know, how are we reassured by this baby's actions if we're not monitoring it for quite a prolonged period of time? So CTG was restarted at 8 o'clock in the morning. Blood pressure slightly raised from what it was previously, but 138/72, pulse of 81, respiratory rate of 18, and a temperature of 36.5. This was your CTG. So the baseline started here at around 140. We had quite a lot of loss of contact. So mum was moved into a right lateral position and then changed to a left lateral position. The decelerations that the midwife had noted were escalated. However, the obstetric registers were in theatre at this point in time. And as you can see, again, the baby's heart rate had shot up to sort of 180, 185 here. Anyone want to comment on this one?
Cara, is there any...
I don't.
Hello?
Hello?
I was just inquiring if there is any documentation about the mother's feedback, how the baby is doing, or whether she's feeding more, baby moving. Or...
Yep, so baby was moving quite a lot again at this time. Lots of fetal movements were felt.
With the uterine activity, is it moderate, strong? Is she feeling it?
Not recorded. So no documentation as to her contractions at this point, unfortunately. Part of our guideline, everybody, is that we should be documenting maternal contractions, the regularity, the strength, the everything, and resting tone should be actually recorded every 30 minutes. This is one of the tick boxes when we're filling out a fetal heart rate as well. It's above it if you're looking the checklist. We should be recording this every 30 minutes, but unfortunately here, this wasn't done. So that's one of my other key messages to come out of this. Now, fetal movements were reported as being really active, which is fantastic, and that does help us with our overall clinical picture. But if we're seeing a woman contracting on the monitor every 2 to 3 minutes, as I am permanently saying, we need to be palpating that abdomen. We need to be palpating for contractions, making sure there's good resting tone, and using our hands-on experience to be able to tell what's going on with this woman's uterus. Because as much as we love technology, it's not always completely accurate. We've got women that we see in triage that have Braxton Hicks. We cannot feel their uterus going hard whatsoever, and yet it looks like she might be contracting 3 in 10 on the CTG, and that's quite common. So unless we actually palpate, we can't know this for certain. So it's so important that we're doing that when we're caring for women antenatally and intrapartum. Mr. Naguib, did you want to say something? Sorry.
Yeah, I wanted just to say that it would have been more useful if we had more CTG over the night, from 10 till 8, to understand the pattern of this baby. Because
Yeah.
I am suspicious that there is, or what I wanted to know, whether this baby does this kind of erratic activity on regular interval or something that that might bring to my attention that like odd scenarios where for example, when the mother is hypoglycemic, for example, this kind of erratic activity happens for the baby. Sometimes it might bring attention to like epileptic activity. Of course, nobody will know for sure, but at least it gives me a bit of an indication over 12 hours what is the sequence of events. But we are where we are, really.
Yeah, absolutely. The CTG continues, and now this is what it looks like. So at 9:40, the registrar comes and reviews and notes a saltatory pattern again with a high baseline CTG for about 30 minutes. This woman had 400 milligrams of labetalol throughout the day for raised blood pressure as well. This was due to the fact that she hadn't had any raised blood pressures in pregnancy whatsoever. And bear in mind as well, she's now 41 plus 4. But for some reason, as an inpatient, she needed to be treated. So they gave her 100 milligrams in 4 different time periods, and that seemed to settle it for about half an hour, and then it went back up again. So we were continually topping her up with this. Something that I just wanted to add with in terms of what you were saying, Mr. Naguib, about pattern recognition and that kind of thing. So I reviewed this case in person, and the only thing I could derive from the pattern is the fact that she'd had something to eat exactly an hour before this baseline heart rate had gone up to sort of 170, 160 on both of these occasions. So on the night before and the morning of, she'd had something to eat very, very quickly before this pattern had happened. So it just made me think to myself, I don't know whether she's eating something that's very sort of high in sugar or something. I mean, we give sort of tea and toast to women in the mornings, or cereal or something like that. But it just made me think, okay, is there a link between foods that she's eating and this baby's baseline? And that's the only thing I could think of.
Yeah, yeah. I have seen some patterns of that, especially when we had a series of diabetic ladies who were induced on labor ward about a few years ago. And when they had so much of hypos, we had decelerations and we had erratic heart activity of the baby. So
Yeah.
yeah, it is possible that it is undiagnosed gestational diabetes or something. Yeah.
Yeah, that was my kind of initial thought. She'd had a GTT in pregnancy, which was normal. And the other thing that made me think, okay, bear in mind she's oligo as well, so that could be something kidney related, or you know, something that's not quite right in terms of her blood sugar management. We didn't do any BMs because obviously there's not really an obvious clinical indication to do so, but looking back at it on sort of reflection, it does make me think, I wonder what her blood sugars were at this point, and whether this erratic heart rate and this high heart rate was something to do with blood sugar management, really. But yeah, I just thought that was antenatally, it's just so interesting, because you don't, this is not something that you see very often, for it to then completely return back to normal again, which it did. In the next segment you see here. So IV fluids were commenced at 10:19. The indication for which I'm not 100% sure. She went out to the toilet and passed a good amount of urine at about 10:10. And then at 10:30 in the morning, they did a speculum just to confirm, to see if her waters had broken, and the ROM plus was negative. So definitely membrane still intact. And she hasn't been re-examined at this point either. The plan was obviously to delay the restarting of PROPES until we were confident that this baby's CTG had completely normalized, because we wouldn't really want to start a PROPES induction on a baby that's heart rate is sat up at 180 in certain cases. But yeah.
I'm not sure I agree with that, you know. We have taken a decision for induction. We are here in labor ward. We are stopping or removing the PROPES to review her in the morning. Then we are concerned that we cannot start the PROPES again. In my book, it is one of two. You are worried, just deliver the baby and section her and finish it off. You are not worried, PROPES her. And for me, I cannot understand what this baby is doing. I would personally go section her and get this baby out. I mean, this limbo all the time in all the cases that we discuss here is a lack of like assertiveness on what you really want to do and what you want to achieve. There is two things here. One is this baby and this patient, yes, but also the overview, helicopter view of the labor ward. You keep stop starting. You are tying a midwife to her, and what is the outcome? She's still closed, and even that she is closed, and she had about 4 or 5 VEs before. Somebody comes in his mind that let's do a speculum, as if, you know, like we haven't touched her before. I mean, it's complete back and forth for, yeah, I don't understand.
Thank you, Mr. Naguib. I think it's I think this woman was very keen to have a normal vaginal delivery. So I think that was very much taken into consideration with this lady. And I think the discussion comes a little bit later. At this point, I think because of the fact the heart rate was at 160 and because of the fact that it had previously been 140, taking into consideration the fetal movements were very, very active and whatnot, and the fact that actually it had previously come back down to a normal baseline, I think even when it comes to sort of the decision making at that point in time, waiting for it to come back and sort of normalize was the general plan, and then make a plan from there as to whether or not it's safe to continue with induction or to offer her and recommend a cesarean section. So in terms of the sort of waiting around in limbo, yeah, absolutely, we do that a lot. But yeah, with this case, obviously she's had a PROPES that then her fetal heart rate spiked and then came back down to normal after it was removed. It's happened again without even having a PROPES induction. So sort of the sit and wait approach was very much used here in the hopes that the decision could be made based off of a normal CTG as opposed to sort of rushing to theatre, which we know it's done previously. But yeah, as you're looking at it now, obviously that's, yeah, it's obviously like you always say, it's very much obstetrics as an art form. So yeah, the plan was to hopefully wait until it sort of returned to normal and then make a plan going forwards.
Tara,
Yeah,
can I
but
make
yeah, go on, please.
Mr. Naguib, I had a case very similar to this one recently on my last set of nights. I had a couple who were incredibly difficult, and I actually told you about them, who were making their own decisions. So they were also induction of labor ward. I can't remember the indication, to be fairly honest, but they were consulting someone who was reading the CTG in another country, and they were literally kind of the most difficult couple I've ever met in my life. Saying that we know our baby, we interpret our baby, kind of making the decision. So I think also like the hesitation, I don't know if this is, I don't even know if this is the same case, but they were kind of like demanding what they want to do. And I think there was, like I couldn't even convince them. I had kind of like hyper-simulation scenario with them, and I couldn't even tell them every decision. They had to consult someone overseas and telling me what to do. So sometimes like we are bound by what the patient wants. Um, like obviously, even if you're thinking it's hyper-stimulation, if they cannot consent for cesarean section, you can't proceed.
No, I agree with you, Maya. It is not. It is not that I am forcing people here.
Mhm.
What I'm saying is, okay, I understand what you're saying, but if we are waiting for things to happen, fair enough. But waiting for things without purpose. If she would have gone in labor, she would have gone. But if she hasn't, and we are not even putting a purpose in, then I am in a situation where uh, I have VE'd her to put the purpose. I VE'd her to remove the purpose. Why suddenly came to my mind that this all were septic and I'm using aseptic speculum? You know what I mean? I know some patients are incredibly difficult, and I remember the case you told me about. And I'm not saying, what I'm saying here is uh, that as even as obstetrician, even that Cara said that we reached the 52 CTG station, we all as a group, and I will put my hand up as well, say that I am not even 1/million of understanding CTGs. And we don't know what these babies want to say. And we don't know. We try to understand. We try to rationalize in our heads and play chess with this baby. But okay, the baby is telling me every time I I I I do something, there is a bit of erratic behavior of the heart that you don't understand. Is it a bit of similar to a case you presented in the past, the pheochromocytoma or rush of some adrenaline that is making this heart rush? Is it the tachycardia of the hypoglycemia as we have it in adults? Is it we don't know. And based on that suggestion, we say, listen guys, not that we are saying this baby is in distress, but the baby, we don't understand the behavior. We don't know what the baby is wanting to tell us. You are 0 centimeter dilated. Not that I am sectioning you at 9 centimeter because I don't understand. And we put all this in front of them and we say, listen, we don't claim to be professorial or understand it, but in our view, get the baby out and deal the baby face to face. I am the pediatrician. I am dealing with the baby. Baby is having hypoglycemia. I am testing the baby. Baby is having something in his lungs. I am intubating the baby. Baby is having something in his heart. I'm transferring to Royal Brompton to do a heart surgery. But at the moment, I am bound to a baby inside the box and I cannot understand it. And as you said, if they want to consult somebody, if they disagree, thank you very much. We are not in Guantanamo. Fair enough. Uh, okay, do whatever you like. But when the baby comes out, in whatever outcome, good or bad, because I'm not claiming that I know all the knowledge, maybe it will be fine. Good or bad, you take it. Thank you very much.
Perfect. Thank you, Mr. Naguib. Just for reference, I think the speculum was used here so that we could get an accurate run plus, because obviously she could have sort of shrum a little while ago and whatnot, and I think it was just another sort of investigative thing essentially, just also due to the oligo as well, which was detected the day before. But as you can see, the CTG came back down and looked almost exactly the same as it did in our initial assessment, but her blood pressure was still raised, 149 over 107, so it's gone up. She was given another 100 milligram of labetalol, and the CTG was discontinued here. At 2 o'clock, she also had a CTG, which was exactly the same, completely normal. Returned back to previous baseline of around sort of 130, with lovely accelerations too. So this was attempt number 2. Just to sort of put into perspective her high blood pressures there, I've just added them at the top. So we've given her more and more labetalol. At 17:46, there was an attempt to restart the induction of labour. That was the decision that was made by the team. Propus was inserted at 17:46. The cervix was 1 centimetre dilated and partially effaced. And here it is continued. So again, some activeness from this baby too. Her bloods came back completely normal, as you can see here. I think her ALP was a little bit raised, but otherwise, yeah, everything was sort of smooth. The CTG was discontinued here as it was completely normal, and then the plan was made for 4-hourly CTGs as well as observations for the night. So the 26th now, all CTGs overnight and during the day were completely normal, which was great. And at 17:50, the propus was removed. I haven't included them all because, as I said, this was quite a long case for you guys. 18:30, she was 2 centimeters and an ARM was performed. She had 30 milligrams of dihydrocodeine here. As you can see, her contractions have seriously picked up here, sort of 4 to 5 in 10. At 20:52, which was sort of 2 and a bit hours after her ARM, cervix was found to be 3 centimeters dilated, and she still had a raised blood pressure, so was treated with nifedipine and labetalol. And at 20:58, she goes on to all fours. CTG looks very, very similar again to what it did initially, which is great. And the CTG continued like this for a little while. So I'll skim through a little bit of this. Loss of contact there at about 21:50, but no decel audible. She is contracting sort of 3 to 4, or if not 4 to 5 in 10 at this point. There was no record of palpating any resting tone. So again, I'm just going to highlight that for what feels like the 100th time about how important it is that we're palpating that abdomen and making sure she's got resting tone, because what I'm seeing at the moment is not a lot of time spent with the TOCO at 0, which in my head tells me, okay, what's the uterus doing? But otherwise, CTG appears to be all fine and dandy. TOCO was readjusted here. She's still got a raised blood pressure, which we cannot seem to get under control. So she's had something like 400 milligrams of labetalol across the day, plus an extra 200 anifedipine an hour ago, and we cannot seem to get this blood pressure under control. But other observations remain normal. She's in a sort of semi-recumbent position here as well. And the TOCO was adjusted at around 22:20. And as you can see, her contractions are coming up a lot clearer on the CTG as well. We continue. Any concerns, queries, questions, anybody?
No, all good.
Perfect. At 23:30, blood pressure still remains raised of 152 over 101. So she's given yet another nifedipine, and it's now the 27th. So she's 41 plus 4. 2 days. Yeah, 41 plus 4 now. Cervix was last examined. Cervix was last examined at about, let's say, 9 o'clock. So we continued. She's in a semi-recumbent position. At 00:49, the cervix was found to be 5 centimeters dilated. So excellent. We've made it into active labor. Still got accelerations. Our baseline has risen slightly, but not more than 10% for us to sort of call this a concerning feature at this point. And our variability is still within sort of a normal parameter, which is great. Blood pressure after that last nifedipine is starting to come down, which is good. And she's being very active. She's moving around a lot, and the CTG monitoring is staying really well. No pain relief on board at this point, just that dihydrocodone she had a good few hours ago. But baseline now sort of 140. We continue. Still at 140. Again, this TOCO gives me a bit of anxiety just purely because I'm seeing very, very little time at the baseline here. We've got no Synto on board either, so these are all her own contractions. And I can't very clearly see how many she's having. It looks like it could be 4, it could be 5, it could be 3. But yeah, again, please record your resting tone with every single patient that you care for. So settles a little bit. She goes out to the toilet. The measurement is not recorded at this point, so it's now about 3:15 in the morning. She has another dihydrocodone, and still we remain the same, which is great. At 04:50, she's made it to 7 centimeters, so she's making really good progress for a primate, which is great. Baseline sort of settles back down to where it was before 1:30. So still continuing with sort of the no hypoxia thought process. And we keep going. Her blood pressure's coming down even further, but her heart rate has now gone up a little bit, possibly due to pain and whatnot, although that's not really reported. And we continue for a while. Any questions, anybody, at this point? We all happy with the CTGs?
Yes.
Yeah. Fantastic. Me too. We keep going. Bit of a decel there, but recovers back to baseline and normal variability. And we've still got accelerations present as well, which is great. Blood pressure at 8:30 in the morning, 121 over 95, pulse of 96, resps of 17, SAPs of 98, and a temperature of 37.0. That diastolic still on the higher side, but I think we probably maxed out on all of the blood pressure medications that we could give her without starting anything rather extreme, which is not really above the threshold for at this point. But yeah, we keep going. At 8:55, I'm not really sure why an in and out catheter was done, why she wasn't sort of up to go to the toilet, but there you go. 350 mils was drained, which was dipped and found to have 3 pluses of ketones and 1 plus of protein. She's had 1 bag of Hartmann's so far. There's not really a lot recorded in terms of what she's drinking orally, but that could be sort of, well, general dehydration. She's not drinking well in labour. And then at 9 o'clock in the morning, the cervix is found to be 9 centimetres dilated. The case midwife attempted to push the lip of the cervix back, which resulted in that sort of 1 minute deceleration that you can see there, but probably more like slightly less than that, but returns back to baseline again. Nice variability. We've still got accelerations, which is fantastic. So the plan was just made to continue essentially, and then examine her in a couple of hours' time, to hope that that cervical lip had gone. So Hartmann's was commenced. This is now the 2nd bag. She's in a semi-recumbent position at this point as well. Doctor's ward round, plan was for fluids and VE in 2 hours by the obstetric registrar. So as you can see, still lovely normal CTG. But Hartmann's obviously to help fluid resuscitation as this woman is very ketotic. Dihydrocodeine again given at 10:18, so this woman is still powering through after a very, very long time in hospital, bless her. Blood pressure of 123/78, pulse of 95, resps of 18, and a temperature of 37.5. Hartmann's was increased to 250 mils per hour as well at this point. But again, we've still got a good baseline, still got accelerations, and we've still got good variability as well. At 11 o'clock in the morning, the VE was done by the obstetric registrar, still an anterior lip, which was unable to move, and she remained ketotic. I believe there was 2 pluses of ketones at this point because they redipped her urine. I can't see the bottom of it, sorry. And yeah, 2 pluses at 11:15 and a trace of protein. So continue with the sort of Hartmann's to try and resuscitate her fluids wise. And the plan was made for an hour of sort of passive descent before pushing, in the hopes that the cervical lip would have gone by then, as it's now sort of been 2 hours from previous. Observations remain stable. Her temperature is still 37.5 here as well. Anyone want to comment anything?
Hi, I noticed that her temperature is going up.
Who is that? Sorry, I didn't hear that.
Her temperature,
Her temperature?
yeah. It's
What
gone
about
up.
her temperature? Yeah,
Yeah,
that's a little bit.
just a little bit.
Just a little bit. So she's had 2 temperatures of 37.5, both within the sort of normal range, but it's definitely something that if this was me and I was the case midwife here, she had 2 temperatures of 37.5, I wouldn't necessarily leave it another 4 hours before repeating it. I'd probably recheck it in a couple of hours instead, or maybe an hour or just before pushing or something like that, just to make sure we weren't heading in the direction of sepsis. However, all other observations normal, and our CTG trace remains completely normal as well. So at 12:12, the cervix still remains anterior lip and the baby is at spines. So the plan is for yet another hour of passive descent, and a peanut ball, because we love our what's the word I'm looking for, biomechanics, to try and get babies into the right position and hopefully get rid of that last lip of cervix. Anybody want to comment? Anybody?
Was it documented what position baby was in at the moment?
I think it was LOT. So the biomechanics using that peanut ball is hopefully going to put baby into the right position as well. It's one of the most most effective ways of moving baby into a right position is getting her onto the one side and yeah, getting the baby into the right position. We've got a baroreceptor D cell there, but this baby's got some fantastic reserves here, considering we've been throwing everything at it for the last, well, 3 days. We continue. Another in and out catheter at 1304, 2 pluses of ketone still. At 1305, the cervix was found to be fully dilated by the obstetric registrar. ROT, my bad, wrong way around. The plan was for 1 hour of active pushing and then plus or minus an instrumental delivery if necessary. Baby still remains nice and stable. Temperature is 37.4, so we're not around that bracket for the need for an aseptic screen, which is good, and other blood observations are normal. Yeah. Anyone want to comment?
I guess, Cara, only just again how happy that baby looks and how much like reserve it's got in the tank. I just wonder when we start pushing, will it look a bit more like that like a second stage trace we're used to seeing?
Yeah, absolutely. Although you'd think, considering this baby's got, it's been going on so long and so well for such a long period of time, that hopefully those reserves will sort of stay intact and it won't stress the baby out very much at all, which would be an ideal scenario. Or it gets to a point where it's kept its reserves for so long and then the CTG goes completely skew with, and we have to intervene a bit earlier.
Also, Cara, about the contractions, we have mentioned several times whether they have been palpated. They look a bit spaced, but I don't know how strong they will be for the second stage.
Yeah, so again, Beatrice, it hasn't been reported. So there's no documentation for it at all. So I think what we're having to go by with this CTG is what we're seeing from the TOCO, because unfortunately it's just not documented.
Yeah, and that is why the baby is quite also comfortable as far as the.
I mean, this baby was comfortable when it was
Yeah.
contracting sort of 5 in 10, so it's probably going to be even happier now that it's sort of more 2 to 3, if you like. But again, just highlighting it. I know I've said it already about 4 times, but yeah, the importance of documenting your palpation is so important. Because you just never know. Perfect. So second bag of Hartmann's was actually now the third, but obviously it's been over 24 hours. And then Synto was started at 13:44 due to the spaced out contractions, and pushing was commenced 2 minutes later. Baseline has gone up slightly, but not anywhere near enough for us to consider this an issue at all. And we started pushing, and this is the next segment for you here. Synto went up to 6 mils an hour at 14:04, and pre-meds were given at 14:10. Pulse now is 114, and it goes up to about.
Cara, what was the station of the head? I'm just wondering the reason for pre-meds.
Spines.
Okay, thanks.
It is noted that this woman's pushing was not particularly effective. But I mean, yeah, we started pushing at 13:46, and it got to about half an hour later is when they decided to give the pre-meds. We at Croydon, we're quite I would say we're quite pre-med happy. Sometimes I think we don't give them enough, and sometimes we think we give them quite a lot, just in anticipation, so that we're not in that specific rush necessarily when it gets to a point if we do need to go to theatre. I think sometimes it's very much dependent on the case midwife and the obstetric registrar on the day. But to save ourselves being in a rush, then we do sometimes give them sort of early if we're anticipating that this baby might need some form of instrumental delivery. Specifically as well, in this case, this baby's ROT as well, so the likelihood of us needing to sort of help them with rotation and whatnot is quite a big thing. And then obstetric registrar came in at 14:45, which was exactly an hour post the pushing process, and then the decision was made here for a trial. As you can see towards the end of the CTG, that baseline does come up and it does then drop into a deceleration down to about 100 before returning to baseline, and then it sort of goes back to where it was settled. This woman consented for a trial in theatre, and then the anaesthetist came into the room to review before we moved. Anybody have any questions, or anybody would have done anything slightly differently or anything like that at all?
I would agree.
Perfect. Wonderful. Mr. Naguib, do you have any comments that you want to add here?
No, it's to be honest, so, like once it's stabilized and everything, it is a very straightforward decision. Yeah.
Perfect. This is your theatre CTG here. So 15:16 spinal was put in. 15:34 an in and out catheter was placed. Cup was on. We had 2 pulls on a kiwi, and then I think we converted to a forceps. I know you can't see it because my stupid bar's in the way for my presentation, but I think the third pull with the forceps was at around 15:42. And then delivery at 15:45. Now, this is the only time pretty much in the entire CTG that this baby's decided to somewhat decompensate by throwing a decel in there. At the beginning of the CTG, the maternal pulse was palpated, which is fantastic. We need, again, that's one of my key messages from this, is whenever you think that you may have a deceleration on the CTG, can we please make sure that we're manually palpating maternal pulse? Because again, I see it a lot where it says it on the OBS machines or on the CTG machines, but actually, again, that can cause sort of like friction with our technology. So please make sure you're palpating the maternal pulse. Sinto remained at sort of 6 mils an hour whilst in theatre, and she was contracting 4 in 10. And then, yeah, delivery occurred. Does anybody want to have a guess how this baby was born and in what kind of condition?
I think normal everything.
Perfect.
I really hope so, for her sake, for the couple's
Like
sake.
on
as well.
Apgars and normal pHs, to be fairly honest.
Lovely.
But
And this
maybe-
woman finally got to meet her baby after about 5 days, which is...
Yeah. I'm really hopeful you're not about to put a spanner in the works by saying it was it came out in poor, terrible condition.
No, well, slight spanner. So this baby was born with Apgars of 7, 8, and 9, arterial pH of 7.08 with a base excess of minus 11.6 and a lactate of 10.3. Did anybody see that one coming?
Nope.
Nope,
Not
me
at all.
neither. Me neither. Venous pH of 7.19, base excess minus 11.5, and a lactate of 9.0. This baby had no delayed cord clamping due to the low Apgar. I think at 30 seconds there was no respiratory effort, and I think the cord was cut and clamped at around 45 seconds. Baby required some facial PEEP in 50% oxygen from birth, and was gradually, the oxygen was weaned down just to sort of air requirement. But yeah, by 54 minutes of life, SATs were 93% in air with normal worker breathing, but just due to that oxygen requirement, needed a transfer to neonatal unit. So yeah, I mean, I looked at this and I thought, super interesting antenatal CTGs. I wonder if this woman did have some undiagnosed gestational diabetes and maybe her blood sugar spiked, which caused this baby to have some dance parties. But then also to have an outcome like this, to come from a baby that's got such wonderful reserves and continues to have wonderful reserves for such a prolonged period of time. I was really quite surprised.
Was this baby treated for choreo by any chance?
I don't think so, Maya, no.
But I'm just trying to think, because the CTG does not explain the pHs, okay? The only thing that's coming to my mind, so the baseline was high, and this woman was on nifedipine and labetalol. So labetalol, I was thinking, should bring the CTG down. So what
Yeah.
could... So we have to admit that there are things that we still don't know about CTG. And I had the case I was mentioning at the beginning is exactly something similar, something I could not explain. I thought it's hyperstimulation, and then the baby completely normalized and we had normal delivery. Exactly the same scenario 5 days later. The only way I could know this is not my case is because I was on night shifts and this baby was delivered during the daytime. So this is definitely not my case, and my baby was fine, and I've done a metal cup. But there was this tachycardia with the propus that I could not explain, and I said this is hyperstimulation, even though I could feel a resting tone, but I couldn't explain it. I think there are still gaps in our knowledge that we have to admit that we don't know. The babies still respond in a way that we can't fully explain with the knowledge that we have, and this is a fact that we should kind of like agree that we still need few there are gaps in our knowledge that we still have to fill in. But this one, now that it's normalized, the only thing that comes to my mind is why we keep on focusing on diabetes. We know that this lady has got high blood pressure, so there is a relative placental insufficiency. So the fact that there's high blood pressure, why are we going to the direction of diabetes rather than thinking, okay, high blood pressure, we use labetalol and nifedipine, there will be in the placenta relative insufficiency, rather than us trying to think, okay, this is diabetes, only because she's got the red herring of oligo.
But then it was also due to the fetal movements. So it was due to the fact that the only patterns that I could to figure out from when those sort of what looked to be saltatory or those raised baselines sort of happened was exactly an hour pretty much after she'd eaten food.
I mean, we're trying to interpret the CTG retrospectively. So we're trying to think, okay, what has happened before leading to this? I mean, unless you had Red Bull.
Well, toast might have had that effect, you know?
Well, it could be like a sugar rush. Absolutely agree. But then we're trying to, so there is definitely, I mean, it would have been very interesting to look into this placenta in particular to see, because I had exactly the same case, which I couldn't interpret. And the baby was born with normal APGARs and normal everything. Now, this baby, unfortunately, was born with a pH of 7.08 arterial, which makes me think now with the high lactate, I'm trying to interpret it with the lactate, but then I'm not sure about the diabetes. What do you think?
For me, Maya, you know why I'm thinking of the hypoglycemia and so on, because if you are thinking blood pressure and nifedipine and labetalol, this is a thing that is happening all the time, like meaning the blood pressure and the control of the blood pressure is a continuous event. Why the baby is reacting up and down with a continuous event, while in diabetes and the insensitivity to glucose and the rush of insulin, there is fluctuation in the bloodstream. So blood pressure, whether it is high, whether it is placental insufficiency, as you are saying, is a continuous event. It doesn't have fluctuation. It doesn't explain to me ups and downs and saltatory movement. Number two, I agree with you on we don't understand many things. And the reason behind that is very simple. And although it is a very annoying thing to me and very sensitive thing to me, the lady who just passed away, she passed away due to what it seems like from the preliminary results, possibly systemic lupus, possibly lupus like reaction, causing like this kind of bradycardia. So even if it is not, every single woman having a baby is having her pre-existing and underlying health conditions: systemic lupus, diabetes, one case you presented in the past, fake chromocytoma, I don't know, Cushing syndrome, Pons syndrome, I don't know what syndrome. So there is hormonal activity in the mother, and this is my opinion. This is the bigger picture that you are talking about that we don't understand. The bigger picture is the endocrine system of the woman, and the endocrine system of the woman secreting different hormones for which the baby is reacting differently, and we don't know. Uh, this is the only ups and downs in the bloodstream of the woman that is affecting the baby, and which will hopefully, like, when we understand more the physiology of the mother relating to physiology of the baby, then we will understand more the CTG. But to have a placental insufficiency by its own causing ups and downs, I can't see why, but you can explain to me if you see it different.
No, I think I can't explain it. I'm just trying to think why there was like the pH was so low. Because the CTG does not really is not bad. I'm just trying to think why would the baby have a pH of 7.0?
I think personally 7.0, 7.19, like 719 is reasonable.
Yeah, but then the
uh,
baby the people needed neonatal admission. I mean, why
because
the baby
because
situation does not translate with the CTG? That's what Kara is kind of trying to show us, is that
yeah,
it's not. So she tried. She saw. This is how I think she picked up the case, because the baby was neonatal admission. I should have thought of that. Like, if the CTG was normal, she wouldn't have picked up the case.
yeah, no,
But then
what I
I
think,
should have picked up bad Apgars just because thinking like, how would she have picked up the case? But
yeah,
like
what I
that,
think,
like I'm trying to explain why did this baby have a relatively poorer outcome.
yeah, I will tell you, like, you uh, go and run. I think you are abroad at the moment. You are in Dubai. So go and run around the one of the big uh, streets, or I don't know, squares in there, and run for 5 days, and come back at the end, and I bet you will be tired. So this baby, we are beating its cage, its environment, for 5 days, and putting propus up, then propus down, propus up, ARM, speculum in, poking here, poking here. So I mean, at the end of the day, this baby should, if it is a human being, should come and say some swearing words, and the least swearing he can say, or this baby, is some bad Abgars. He cannot maintain a normal gas and normal everything after 5 days of a marathon. So I mean, it's not that I'm seeing the last hour of CTG and saying it is normal and baby should come normal. We are interpreting again the CTG. I'm feeling that there is the bigger picture, which is a human being, and not only the lactate and the and the bicarb that we keep talking about in the usual CTG teaching. There is many other things. So yeah, I mean, yeah, baby had enough, really.
I think that's probably the only way we can describe it, to be honest. Does anyone have anything else they would like to add to this case at all? I think it's been a fantastic discussion, so thank you everybody for contributing.
Very interesting, Cara. I've seen a couple of them now, and very, very interesting. I think we can do lots of research on this hyperstimulation or tachy trait explainable cause, or we can there's lots of things that could come out of this, to be fairly honest.
Yeah, there's so much more work to be done at the end of the day. There's
Exactly.
an abundance of things we don't know.
Yeah, so it will be lucky if we can take part of this.
Hopefully.
Yeah. Thank you so much for picking these cases. Thank you.
No worries. Thank you, everybody. Hope you enjoyed that one.
Thank you. Yeah.
Thank you, Cara,
Thanks,
so
Sam.
much. Very interesting. Thank you.
No worries.
Bye.